My name is Majid. I'm one of the clinical pharmacists and one of the independent prescribers that works for Medical Mojo. I'm here with my colleague, who is also an independent prescriber and a leading authority, I'd like to call him, on multiple conditions that we deal with. Our background is primarily we're both clinical pharmacists. My background in particular is I've been a pharmacist for 30 years and I've been working in general practice for the last 10 years. And I cover a variety of long-term and acute illnesses within the scope of my daily practice. And for the last 6 months or so, we've been working together on a company called Medical Mojo, and we trying to provide alternative and original solutions to the multitude of health conditions that isn't normally covered under normal conventional medication.
Thanks, Maj. So my name is Shazlee Ahsan, and I'm also a prescribing pharmacist. I had an interest in endocrinology, so I've got a master's in clinical endocrinology, and I think this gives us a holistic approach to the way we look at illnesses. So what we try and do at Medical Mojo is it's not a one-size-fits-all model, because everyone is different, and we try to create this holistic approach. So we don't look at things in isolation, because everything is connected together. And using Majid's extensive experience in community, where he basically runs GP surgeries, we're able to identify those long-term conditions which haven't been treated well, and hopefully find solutions for these patients using compounding and using repurposed medicines, which we're going to come on to.
Yeah, perfect. Right, okay. So, in terms of our patients and the sort of patients that you and I are both talking to and dealing with at the moment, we'll just give, obviously, the listeners a background into them. We tend to cover a wide variety of illnesses, things along the lines of fibromyalgia, MCAS, hashimotos, pain relief, and long COVID. I don't know whether you want to add to that or
not. So you had long COVID, chronic fatigue, fibromyalgia, hashimotos. You've also got the autoimmune conditions, even multiple sclerosis, Crohn's disease, inflammatory bowel disease, anything of that nature. I think, what are we seeing a lot of? Fibromyalgia and chronic fatigue.
Yeah.
And long COVID.
Long COVID, yeah. Okay, so in terms of, the way our company, or our pharmacy and our compounding services work, we normally tend to have patients fill out a consultation form online, which they'll submit, and then one of our clinicians will review the form, and then based on the information that they give us, we can then try to decide with the patient the best treatment pathway for them. Firstly, like I said, in the first instance, it's a consultation form, and then if we do need extra information, we'll have a chat with them, either a telephone call or a video conference, and we can then decide what we need to do going forwards. As Shazlee just alluded to there, we are also a compounding practice, which means that we tailor medication specifically. As I was saying, so we make medications, compound them, and we'll supply them appropriate to the patients as we decide. So, I suppose in terms of medications that we are seeing a lot of now, Low Dose Naltrexone, LDN, almost like a go-to for us now in terms of patient treatment, because it covers so much. And we'll talk to you a little bit about the mechanism of action. Obviously, I'll let Shaz explain that, because he'll probably do it a bit more succinctly than I can. So, Shaz, let's talk about LDN.
Yeah, LDN, it's one of those drugs that everyone's talking about, and it seems like it's too good to be true. It seems like magic. When I was speaking to my sister and I was explaining all the benefits of LDN, initially, she was interested because she has an autoimmune condition. But the more I started speaking, she kind of was looking at me as if I was a snake oil salesman.
Right, okay. Let me stop you there for a second. I want to just give a bit of context in terms of low dose naltrexone. in the UK, the low dose naltrexone is only licensed for the treatment of opiate addiction because it's an opiate receptor blocker. Yes.
Yep, that's right. Yep.
And so normally it's given at doses of 50 to 100 milligrams, and the patients take it obviously to counteract the effects of either opiate overdose or managing those type of scenarios. So yes, so going back to what we are saying then, so LDN, we're prescribing it at a much lower dose, hence it's called lower dose naltrexone. And I'll let you continue. Sorry for interrupting you.
I mean that's the first thing when you talk to doctors and you're trying to explain about low dose naltrexone. Immediately they've got this image of using this for opioid addiction or alcohol withdrawal because at the 50 milligram dose it blocks opioid receptors. So a bit of history. It was first synthesized in I think 1963. And the American government had a big push behind this because there was this opioid addiction epidemic going on in America. So with heroin, morphine. And so they wanted to develop a drug that would sit on a receptor, opioid receptor, and then not activate it. Yeah. So I think maybe explain what receptors are, first of all, if people don't know.
Yeah. So basically, in terms of basic biology, a receptor is exactly what it says on the tin. It's it's a mechanism by which something can come and attach. So a molecule or a compound would come and attach to a receptor and either activate it or block it. I think that's the easiest way to describe it.
Yeah, I mean, I always, when I'm talking to patients, I would say it's like a key and a lock.
Yeah.
So that the key is the drug and the lock is a receptor. You put the key in, you turn it, you get a response. So imagine you have heroin, heroin's a key, comes into the lock, bang, you get the pain relief, but also get that euphoric feeling. So naltrexone is like, imagine you put putty in the lock. That key can't go in. So essentially that's what naltrexone was doing. So you occupy the receptor. So no matter how much heroin someone took, it's not going to have an effect. So that was its primary focus, and it was released in, I think, 1984, I believe, or something, the 80s, to deal with this epidemic. The interesting thing happened in 1985. There was a physician called Bernard Bahari. He was a Harvard-trained neurologist, and he was working with AIDS patients in New York. And he started experimenting with naltrexone, but at lower dose. The full dose is 50 milligram, and you get a total blockade of the opioid receptors. Okay. So imagine you have 5 receptors, 50 milligram, all are blocked. Okay. Now, what he did, he reduced the dose to about 4.5 milligram in AIDS patients who are also addicted to heroin. And what he found was they were making really good improvements. I mean, the way you measure, like someone with HIV AIDS is their CD4 count. Their CD4 count was increasing.
Okay. So just for the layman, what's a CD4 count?
So HIV is a virus that attacks the immune cells. So we measure this by counting a particular type of immune cell called a CD4 cell. So when your CD4 cell count goes below a certain level, that's when you get these opportunistic infections, which actually kill the patients. Normally we would just bat them off because we have adequate CD4 numbers. But what was happening in these patients, the naltrexone at the lower dose was doing something to the immune system to strengthen it or to modulate it. Modulate is a better word. Then following on from that, you have 2 researchers, Ian Zagon and Patricia McLaughlin at Pennsylvania State University. They took the initial findings from Bernard Bahari, and they developed it. And before we go any further, we just have to say that opioids combine to a number of different receptors. You've got the mu, gamma, delta, zeta, and the zeta is also known as opioid growth factor. Now, Ian Zagon and Patricia McLaughlin, they worked on the opioid growth factor. And what binds to the opioid growth factor is an endorphin, an endogenous endorphin, because we make our own painkillers, endorphins and enkephalins. Enkephalins are slightly smaller, endorphins a bit longer. And this particular endorphin, metenkephalin, binds to the opioid growth factor. Okay. What they found was when the metenkephalin bound to the opioid growth factor, it actually stopped cellular replication. Okay. So this is great. I mean, where is it where cells are just running rampantly out of control? It's
Yeah.
cancer.
Of course it is.
So,
Yeah.
so at a low dose of naltrexone, you can actually stop that cellular growth. And there are case studies where LDN has been used in cancer. Okay,
Right.
but
Okay.
more research needs to be done.
Right. Okay. So what we're going to do now then is, I'd like to talk to obviously everybody who's listening to the actual mechanism of action of LDN and what it does. So, right. So the first thing that we've said is that we know that it blocks the opioid receptors. Modulates. Sorry, not blocks. Modulates. And then what that does is that
Yep.
produces a response. You release your body's own natural endorphins, what the general public would say the feel good hormones,
Yeah.
essentially. And then that produces a response of either pain relief or a feeling of well-being. So that's the one mechanism of action. There's also a second mechanism of action as well, the glial
Yeah.
cells.
Yeah. So you're absolutely right. It's like, so we got ahead of ourselves. So when the naltrexone at the full dose, it's given at 50 milligram, it blocks all the receptors. At the lower dose, it only blocks, say you have 5 receptors, it will only block 2 of them.
Yeah.
And so the brain interprets this. It says, oh, we don't have enough endorphins, or we don't have enough receptors. So what it does, it upregulates to overcome that block. So you trick your
Yeah.
body into producing more of your own feel good
Yes.
endorphins. So that's one mechanism. So you get more pain relief, because you've tricked your body into making more. It's like that runner's high, So you're tricking your body to making its own natural painkillers. But that's not the only way it works, because if we look at our hands, we've got a left hand and a right hand, Now, we can do that. I can't superimpose them. They're different. So drug molecules, they come in a left-sided version, a levo, and a right-sided version, dextro. Levo, it does what it says on the tin. So with naltrexone, this is the levo version, blocks opioid receptors. Whereas the dextro, we only find this out when we use it in practice. And then we get an understanding, we get an inkling of what it does. And the right-hand side works, and this is where it modulates the immune system. And it does this by working on, imagine you have like the nerves, and there's immune cells that work as a kind of scaffold around the nerve cells. They're called glial cells. Now, what naltrexone does in lower doses, it modulates the glial cells, so it can modulate the inflammatory response. It can dial it down. It's not like a sledgehammer to crack a nut. So, a lot of autoimmune conditions, we wipe out the immune system, and so you're vulnerable to bacteria and viruses. But what LDN does is it modulates it. It's like a thermostat. It turns it down. There's also, so it does this by modulating the environment of the glial cells. And then further research found that it actually acts on a receptor called the toll-like 4 receptor, TL4 receptor. So imagine these are like fire alarms on your immune cells. So when it encounters a virus or bacteria, the bell starts ringing and it starts releasing messengers. These are called cytokines. And an easy one to remember is, and they IL-6, stand for interleukin, and there's loads of numbers. But easy one to remember is interleukin 6. Just remember 666. If you've watched Damien Omen, you know what that is, So it's a very bad thing.
I'm sure most people would get the reference,
Incidentally, we do a genetic test where you can find your susceptibility to raised IL-6 levels. So I know I've done this genetic test, the Nutrigen test, where my inflammatory markers, if I don't do anything about it, I'm predisposed to high IL-6 levels, which means more inflammation. And again, this opens a door for chronic conditions such as type 2 diabetes and cardiovascular disease. So IL-6, like the 666, it's a bad thing. So when a virus or bacteria or even the self activates the toll-like 4, the bell starts ringing and it starts releasing these messengers. One of them is interleukin 6. Now, LDN blocks that message. It sits on that toll-like 4 receptor, and so that immune cell is not activated. So we don't get that immune response, that inflammation. We don't get that propagation of IL-6. So that's another way that it works. So you get 2 for 1, pain relief and modulating the immune system.
Brilliant. So, which is why then when we listed the conditions, that we actually deal with. So, we talked about obviously fibro, we talked about MCAS, we talked about hashimotos, long COVID. All of these have not only, I mean, are you managing the pain, but then you're modulating the immune system response as well, yes?
Yep. So if I can ask you, Maj, because you've worked in community in the GP practice for a long time, you see fibro patients, and what would you typically? I know you're not allowed to really prescribe LDN on the NHS because you'll get into trouble,
No,
but
no. So essentially, unfortunately, I should say, the way I suppose in my practice and in my experience, fibromyalgia patients are managed is that a diagnosis is made, whether it's normally done at the surgery level or the patient is referred to a specialist pain management clinic. And then, unfortunately, the treatment tends to be the the pain step ladder, or the ladder as we like to call it. So you'll try a patient on something like a paracetamol or a like a NSAID, and then obviously you'll go up the ladder depending on their response and how they feel. And I mean, unfortunately, yeah, I mean it tends to be dealing with the symptoms of the pain rather than trying to treat the underlying condition as such. So yeah, normally, like I said, normal analgesia. Then you'll probably escalate to maybe a non-steroidal. If that doesn't help, then you're talking gabapentinoids and pregabalin. And then if that doesn't help as well, you'll then go to opiates. And then basically it's then almost like a juggling act, trying to find a balancing act of which treatment therapy works for the patient best. Unfortunately, with some patients, these things aren't effective enough. So then they start doing things like lignocaine transfusions and nerve blocks. And I mean, if you've got some, I mean, and this is one of the things that attracted me personally to this and what we're doing at the moment is, I mean, you've got something that's far less invasive, far more cost effective, that produces proven, measurable benefits. Like I said, I've been doing this for the last 6 months now, and not only do I initiate treatment and supply the treatment, but I'll do my follow-ups as well. I'd like to do my due diligence as well, and the success stories that you hear, it's amazing. It is literally that. I mean, you know how you said your sister said it was a miracle drug. It is that because it works. I mean, I was speaking to somebody, and this chap, he's based down in Wales, young, fit, and healthy chap, got COVID, and unfortunately, it was debilitating for him. So essentially, he was almost bedbound. I mean, he'd go somewhere out of breath, fibro fog, a brain fog, and just very, very, very poorly. So he started LDN treatment, and it has transformed his life. He's up, he's about, and he's walking, talking, and he's back to living. He's not living the life that he was before, but he's 60 or 70% of the way there, rather than him being just, not being able to do anything. So, and I see this more and more with a lot of the patients that we're dealing with at the moment. So, yeah, it is a miracle drug. It is working. And obviously, you've got to do your due diligence in terms of, the way that you start the patients on medication and what they require specifically for them. But then it's the follow up as well. So we need to have, we have those processes in place now where we can monitor and manage them appropriately in regards to their symptoms and their journey.
Do you know, for example, because you've seen like both worlds.
Yeah.
I mean, I haven't really worked that much in community prescribing. I dove straight into private practice. Initially, we did PRT, testosterone replacement therapy. Then we did this. And what we found was that a lot of the guys that we were seeing in the testosterone replacement clinic, they had low testosterone from, guess what? Opioids. Long-term opioid use decreases your testosterone levels.
Yeah.
Now, coming back to the patients that you saw when you were treating them for fibro and you were giving them gabapentin, how did they feel this was helping their condition? Because when I speak to some of those patients, they said that, yes, it helped, but I just felt monged out. And when I was taking opioids, the pain's still there.
Yeah.
I just didn't care. Yeah.
And that's exactly it, unfortunately. As well as I do. If you take an opioid and you're opiate naive, then it's going to be quite significant in terms of the effect that it has. But like everything else, unfortunately, your body, for want of a better phrase or term, gets used to it. And that's the same with gabapentinoids, and that's the same with pregabalin and those sort of medications as well. I mean, you'll use this medication, and unfortunately, your body gets used to it. So then what do you have to do? You have to escalate the doses until you get to a maximum tolerated dosage, whether that's governed by what the patient and their side effects that they can handle, or whether it's just the maximum dose that you can give them without doing them any harm. And then unfortunately, you're at a status quo. So I mean, and that was it.
Yeah.
So
I mean,
nothing more.
I was what makes this so rewarding is what you said, like you've had that interaction with a patient in Wales. I remember we had a woman and she phoned us back in the day when we just had a supply problem with LDN, and she was desperate. She needed it because she said before, with LDN, it was the first time she didn't have to take paracetamol in 20 years. So it's just a simple drug and it's safe as well. I mean, I think we just, if you've got a liver problem or kidney problem, this is how you get rid of drugs from your body. If they're not working, then there's a bit of caution. But the main side effect, which I take LDN because I'm predisposed to high IL-6 levels, and it actually works for my lower back pain as well. One of the main side effects, which I don't really mind and actually look forward to them, is vivid dreams. About 40% of people get vivid dreams. So that it's crossing the blood-brain barrier, and it's having an effect on your REM sleep. So, but in terms of side effects, that's the main one. Maybe a bit of nausea, vomiting, but we titrate as well. We titrate.
So yes, I mean that's what I was going to say as well. I mean, I think that's something else that's novel in what we do in our approach is that we'll always start the patient on the lowest dose that we can. I mean, I know that we have capsule form that we produce as well in house, and we also do a liquid titration as well. So whatever form the patient suits the patient. And what we'll do is we'll start on a low dose, and then we'll tend to increase by 0.5 milligrams until they find a dose. And I always say this, I know 4.5 milligrams is the normal standard dosage, but I always say go by what your body's telling you essentially. But if you've got relief at 2 milligrams, then please by all means stay at 2 milligrams. And if you do then need to increase the dosage, you can. But yeah, I mean, like I said, whatever works for the patient, I think that's the important thing here. I mean, but going back to what you were saying in terms of vivid dreams and what have you, we do offer solutions in terms of managing those sort of symptoms as well. So, I mean, obviously, we do the 3Rs. I mean, do you want to talk about the 3Rs at all, or?
Oh, 3Rs for the chronic fatigue syndrome.
Yeah,
I'm actually wearing. We have the 3Rs here. So for chronic fatigue, we came up with evidence-based solutions to help people deal with their chronic fatigue, where it's a normal person can just be struck down.
Right. Let's define chronic fatigue first. Chronic fatigue is what? It's essentially
a post-viral infection. So, I would say to people, a lot of health professionals, unfortunately, as well, and just general people who don't know about chronic fatigue, they think someone who has chronic fatigue, they can't get out of bed, they have to watch what they're doing, they pace themselves. So they're moving, it's like they're moving in slow motion. And that's for a purpose because they understand they have an energy envelope which they have to remain within. Otherwise, they get something called post-exertional malaise, where you can do something that normally used to do and it knocks you out. So this is a post-viral infection. And for people who think it's just, they're making it up, it's not a serious thing, I would say go and watch Awakenings. It's an old film. Well, it's Robert De Niro and Robin Williams. Tells the story of Oliver Sacks, and he was dealing with this cases of post-viral infections where children had like something like the flu, but then they slipped into a coma. And Robert De Niro's character slipped into a coma when he was a young child after having a viral infection, and he wakes up as a middle-aged man. And it's Oliver Sacks's attempts to, I think it's Oliver Sacks, I'll have to check, but his attempt to try and, get him adjusted to the world. And he had a deterioration where he was developing Parkinson's disease, and the doctor was dosing him up. Robin Williams was dosing him up with dopamine. But it's essentially chronic fatigue syndrome is a post-viral infection. Okay, so you've had your virus. Epstein-Barr virus is a classic one. So it's the kissing disease. Adolescents get it because they start dating, and then so they get this and then they just wiped out. It's not this normal fatigue where you're tired, you go to sleep, you wake up fresh. You go to sleep, but you're still tired. It's just like you physically can't do anything. So that is the type of fatigue we're talking about. And there's a number reasons behind that. There's a number of ideas, and before it wasn't well researched, but now we come to think of it like as a few ideas that researchers are throwing around, like the body doesn't quite clear the virus. And so you have things called antigens. These are things that stimulate the immune system and they hide around the body. And then what you get is your immune system is not on full blast, it's on simmer, right? Now, if you keep your cooker on simmer, your bill is going to be high. Your gas bill is going to be high, isn't it? Because it's not off, it's simmering. And so think of that to your energy packet within your body. Your immune system is always on. It's simmering in the background, okay? Now, and it's drawing energy. We know our immune system draws energy because when we're ill, when we're fighting an infection, say you have the flu, you're wiped out. And an easy diagnosis, how do you diagnose the flu? If someone comes to me and says, what's the difference between the flu and a cold? Quite simple. I'll take out £10. I'll put it on the floor. If they can walk 5 paces, pick up £10, they've got the cold. They would not be able to do that with the flu. Because when you have the flu, you have this viral infection. Now, your body doesn't want you to waste energy. It wants you to focus on healing. So that's why you feel lousy. That's why your temperature increases. This will help clear the virus. And what do? We try to lower the temperature. So the temperature increases and we feel lousy. We want to sleep because when we're sleeping, we're not expending energy. We can shuttle that energy to the immune system. Now, coming back to chronic fatigue, we haven't turned the immune system off. So it's draining our energy. Usually, our immune system gets it works best. It recharges and does its systems check at night when we're sleeping. We're not expending energy, but we're still expending energy on our immune system, which is why if we don't get enough sleep, our immune system hasn't had the chance to do the systems check. And we're vulnerable to infections. We're vulnerable to cancer. So sleep is super, super important to help our immune system do its job. So if we have this low-grade inflammation, infection, it's drawing out energy, which is where...
So I'm going to guide you back to the 3 R's now. So what are the 3 R's then?
The 3 R's are recover. How do we recover? We use LDN. We're tackling the inflammation. We're modulating the immune system. We're turning that dial down. Then we've got rest. Because we were talking about sleep and the immune system. So melatonin, because melatonin helps us sleep. Melatonin is the vampire hormone, which is produced from the pineal gland, only comes out at night like vampires. And it does more than just help us sleep. It's actually anti-inflammatory. Melatonin is quite interesting as well because Denmark was the first country in the world to offer night shift workers compensation when they developed breast cancer. These are nurses. Long-term, they're working night shifts. When you work night shifts, you're exposed to artificial light, blue light, and you suppress the release of melatonin. So this demonstrates that melatonin has an important role to play. We release it, it helps us sleep, but it also helps reduce inflammation. The final thing is, so we got recover, rest, recharge. So what do we do? So we need to recharge our power plants, our mitochondria. And the way we do that is with coenzyme Q10, which has 2 roles. Is an antioxidant. So it knocks up free radicals. Think of these as kind of like sparks from energy generation that cause little fires. So it's like little fire brigade, and it helps make energy as well with the electron transport chain. But a lot of biochemistry. But in essence, it supercharges your mitochondria, your power plants. You get 3. So this is what the 3 R's stand for: recover, rest, recharge. LDN, melatonin, and coenzyme Q10.
Perfect. So, like I said, and what I'm tending to find as well is obviously the patients. Like I said, LDN by itself, brilliant, does the job. But obviously, when they use it in combination, the 3 R's, they tend to have a much better, I'd say, outcome in terms of their health and the way they feel. So I'm glad we spoke about that as well. Right. Okay. So, should we talk about how we actually manufacture and do our medications? Do you want to talk about that at all, or?
It's a good point because you can't if we was to order from naltrexone from a pharmacy, we'd get the 50 milligram strength. Now, I know everyone's thinking I'll get the 50 milligram, break it up, and make it my own, but it's not precise because
easier said than done.
If you want to have 1 milligram capsules, then how you're going to determine there's 1 milligram and everything. So this is where compounding pharmacy comes in, where we get the API, the active pharmaceutical ingredient, which is naltrexone, and then we can either put it in a solution or capsules, and they're vegetarian capsules. And with the solution, sometimes we have patients who ring up and say, look, can you do it without flavoring? So we have a tutti frutti flavor. So if you don't like tutti frutti, then you can get rid of that. It's made out of, like, the base is water, purified water, so it has a limited shelf life, 35 days, need to be refrigerated. We usually use that liquid, as you mentioned, to titrate the dose. A typical titration regime is 0.5 milligram each week, titrate up by 0.5 milligram each week until you get to a dose that works for you. It doesn't have to be 4.5 milligram. And even in some cases, we were speaking to another colleague who does a lot of work with POTS and MCAS, and they were mentioning, and long COVID, they were mentioning that, there's other, like, people go up to 6 milligram, and sometimes people do twice daily dosing. So I was thinking of this because when you look at the half-life of naltrexone, I can't remember what it is. I don't think it's not long, 7 hours.
No,
I think, after check.
Was it 17 hours? I don't know. Yeah, don't quote me, in fact. So
it's actually, let's have a look. What is it? Half-life.
I should know this because I did some work. I did a paper the other day, but I can't remember.
4 hours.
All right. Okay. So yeah, not long at all then.
4 hours. So this could potentially, because I was looking at, because when I take it for my low back pain, so in the morning I get that relief, but then, and in the evening you start feeling it again. So I'm just experimenting. I'm thinking, should I take it again? Because
so you do realize that you just used a scientific term, half-life. I don't think a lot of people know what a half-life is. So should we explain? A half-life is essentially, so you take a drug, and it's just, say, for example, it's excreted over a certain period of time. So the half-life is the time that it takes for half of that drug to be excreted from your system, yes?
Yeah. So it's why some of the drugs, like, for example, the weight loss drugs, semaglutide, tirzepatide, Mounjaro, Wegovy, it's got a long half-life. So you take it once a week. Once a week. But your antibiotics have a short half-life, taken 3 times a day.
Yes.
So to maintain steady levels.
Yeah. Perfect. Right. So So sorry. So we were saying about the dosing of naltrexone. What you're thinking? Potentially twice a day dosing.
Some people do that. It's not common. Yeah, but it's like.
I was going to say I haven't seen it before myself anyway. And obviously I've seen the once daily dosage that most people tend to find. But I suppose this is relatively new territory, isn't it? So
potentially 6 milligrams has been documented. I mean, one guy, he was saying, look, like, we know one of our customers is 6'5", so he's saying, look, would I be taking the 4.5? And that was a good point. So maybe 6 milligram could be an option, but I wouldn't really go higher than that. And
are we talking in 2 doses then, or so 6 milligram?
6 milligram with 1 dose, and then twice daily doses. I have to do some more research, but I will experiment on myself. And I'll let you know.
Fair enough. Okay. I know you talked about you using it for your lower back pain. So, are you using it in line with other analgesics, or is it just the LDN that you're using now?
Just the LDN.
And how's it managing your symptoms?
It's fine. It's actually the only pain relief I have. It's not super bad, but predominantly, initially, why I wanted to take LDN was because of my genetic predisposition to high inflammatory markers, IL-6, and we know LDN blocks the production of IL-6. I mean, maybe in a later video, I'll go through my genetic test.
See, you've just said there then genetic testing. See, I'd like to get mine done. I haven't had it done yet so far. I mean, at the moment, touch wood, I don't take any long-term medication. I'd like to think I'm reasonably fit and healthy. But yeah, like I said, I mean, we're all of a certain age now. And obviously, as you know, once we get older, our lifestyles here in the UK aren't the best in the world. I mean, we're not really outdoorsy, so you've got to, struggle to do things. So I'd just like to have, for my own peace of mind, a genetic test done. I mean, what does that look like? How much does it cost? Let me know. What are we talking here?
So the Nutrigen test, it is quite expensive. I think you're looking about maybe £300 to £400, or even higher at some places. I can't remember what we sell it for. I think we sell it for about 400. but
Okay.
that comes with an in-depth consultation. So
Okay.
that looks at something called SNPs, SNP, single nucleotide polymorphisms. Now, when you have like a slight variation in your code, DNA code, so you have like DNA is made of a code, yeah.
Yeah.
Now there's 4 letters. What is it? A, T, C, G, yeah.
G. Yeah.
And then you can have variations where, like it might not be an A, it might be something else. Okay.
Yeah.
And that produces minor variations in how that protein works. So a classic example is an enzyme called methylene tetrahydrofolate reductase, MTHFR, to do with methylation, a very popular one.
Yeah.
Now, I know I have a SNP, which is a very popular variation, which makes my enzyme 30% less efficient. So
Okay.
I am methylating 30% less. And that has a
Yeah.
knock-on effect because methylation, this enzyme is responsible for about 200 reactions, making neurotransmitters, adding methyl groups to things,
Okay.
and when we add a methyl group to something, it helps getting rid of something out of the body.
Yeah.
For women, it's really important for estrogen because methylation helps put a methyl group on estrogen, and also men to get rid of estrogen. So if you've
Yeah.
got poor methylation, then your estrogen is going to build up.
Yeah.
And then you're going to get those symptoms. So with women, they'll get those. And remember, any kind of symptoms, like a menstrual cycle where it's just like really, like, how can I say? It's like yin yang. It's like super high, like aggressive type, or is that wrong type of word? I don't know. But not because progesterone is your like yang.
Yes.
Estrogen is your yin. That's
Yeah.
like that causes all the negative symptoms. Progesterone just is that calming
Yeah. Calm.
hormone. And
Yeah.
we actually compound that. And if we're not careful, if we don't put it in the fume cupboard and we don't wear all the protective kit, everyone's asleep because that's what progesterone does. It's a calming
Yeah.
effect.
Yeah.
A lot of the times when we're looking at this comes back to that holistic approach. If we know the genetics, if we know your blood markers, and if we know your symptoms, then we kind of got an idea of what's going on. So for women who experience extremely bad menstrual cycles, maybe it's because they're producing too much, because they produce the estrogen, they're not methylating, they have a reduction in their MTHFR gene, 30% sufficient enzyme, which means they can't get rid of that estrogen.
Yeah.
So it's
So, I suppose, the next logical thing to say would then be, if you are going to get a genetic test, obviously it would be interpreted for you, and then you'd be offered some kind of solution in terms of how to combat those deficiencies. Yes.
Yeah, 100%. I think what a good thing would, because I did this experiment. I did my genetic test, and then I went cold turkey on all the supplements and testosterone that I take because I wanted to see what my baseline was. If I didn't do anything, because I know I have the risks from the genetic test, and I took a blood test, and it was quite surprising because I know I have this predisposition to high inflammatory markers, IL-6. And when I did my blood test without taking testosterone, without taking coenzyme Q10, anything to dampen or LDN, in fact, with anything to help reduce my IL-6 levels, my CRP reading, which is a measure for inflammation, is through the roof.
So CRP is C-reactive protein for anybody that doesn't know. Yes.
What's the limit where you start taking notice?
If you're asking me those sort of questions, Shaz, it's 9:30 at night.
Yep.
Yep.
Five. Five. Mine was.
Go on.
30.
Wow. Okay.
Yeah.
And this was your baseline bloods, yeah?
Baseline. Because what I've got one kidney. I donated one kidney. So there's a lot of stuff going on. So and that was just, me leading a bad lifestyle as well.
Okay.
Yeah. And also, when you look at all my other genetic factors, being of a South Asian background, predisposition to type 2 diabetes, which is all shown in the genetic test, then that shows you if you do nothing, what happens. So that, like, again, using the evidence from your genes and then having a baseline, you have to do something. Otherwise, it's not looking good.
Yeah.
So that's why I take LDN.
So I always advise, before I start patients on anything, I do always advise just to get bloods done because, it gives you exactly what you said there, the baseline, and you've then got a datum to work against. because like I said, everything we do, I mean, not only is it based on, guidelines and what have you, but it should be based on empirical evidence as well, how a patient reacts to certain things. So you need to know where they're at. And then obviously, once you've done some kind of treatment or you've provided them with a solution, at the end of it, you want to see what sort of difference is made as well. And then that's like a quantitative measure of, the treatment is working, isn't it? So
exactly. And do you remember we was discussing that today about the TRT clinic, which we're going to be setting up soon?
yeah,
Even young men, what they should do, even if they feel, actually, it's really good when a man is in his 20s or 30s and he's on top of the world. Yeah.
yes,
Get your bloods done, because
yeah,
that's your baseline. Later
yeah,
on in life, your testosterone is going to decrease.
well,
And if
yeah,
we have a baseline where we can say, okay, remember how you felt when you were 20? We want to get you
yeah,
back to those levels. So
yeah,
even if you don't need that test, get a baseline test.
yeah,
And I think it's something that you can always refer back to. When in your
yes.
peak of health, get your blood test done so you know where you need to return to.
Yeah. I mean, just a bit of a side note then for anybody that's listening. Essentially, testosterone levels start dropping in your 30s, yes?
Yep.
So once you're past 30, you're never going to be the same the way that you were. So it's always a good idea to get your bloods done. So it's like you said, you've got something to aspire to work against, essentially, yeah?
And unfortunately, also, which is documented in the studies, and we'll go over those studies, generationally, we have lower testosterone than men who are in the 50s. And
Yeah,
it's due to the environment, due
yeah,
to that we've put on more weight. And we'll explain how putting on more weight, obesity can actually lower your testosterone is really, really interesting.
yeah,
Uh, Also, we're surrounded in a toxic environment which is full of estrogenic compounds, bisphenol, and I'm drinking out of plastic bowl.
yeah, yeah,
And so, so we're surrounded by that. So, and that's playing havoc with our hormones.
yeah,
And again, that has a knock on effect because we know testosterone is an anti inflammatory. And this was one of the reasons why during COVID, a lot of elderly men passed away because they had a low testosterone level. And then what killed people in COVID was the cytokine storm, where the body reacted against the virus in
yeah,
the second week or so. It was an
yeah,
overwhelming immune response. Now,
yeah,
if you've got adequate testosterone levels, it's kind of like a brake on your immune system.
yeah,
If you've got low testosterone, that's gone.
yeah,
So all of these things, that's what makes this project that we're doing so super, super interesting, because we're not treating the symptoms. And this is the whole ethos of functional medicine. You look for
yeah,
the cause,
yeah.
find that root cause, and it's a holistic journey, which
Yeah.
can even simply mean changing your lifestyle, changing your diet,
Yeah.
doing simple things.
Yeah, I mean, and that does have a massive effect. I just wanted to go one step back, though. I mean, obviously, you and I, we've been in medicine and working around medicines for the last 30 odd years. I mean, we've known each other since sort of like the mid 90s. There's been a vilification of testosterone and testosterone replacement therapy by conventional medicine, in my opinion, because not much was understood about it. I mean, so whenever you hear about it, I mean, it's like anything else. I mean, obviously, with a medication, I mean, you can use a medication and you can abuse a medication. And unfortunately, the information or the images that are sent out in regards to testosterone is normally of these massive bodybuilders that are using these super physiological doses, and it's going to have a negative effect. We're not saying that at all. What we're saying is we're going to. I mean, like females have a menopause. I mean, I think it's been quite well documented now that men go through something similar, but it's just not recognized or noticed as much. And we want to try to do something to help men who are further on in their journey of life, to try to not only maintain but to help them enjoy their life the way it should be. Yes.
Well, 100%. You're absolutely right. It's like there was that stigma attached to testosterone because, yeah, when you say testosterone, everyone thinks roid rage, everyone thinks bodybuilders,
Yeah.
and like it's the extreme. But and they say that taking testosterone is so dangerous for you. It's going to cause heart attacks. It's going to cause prostate cancer. But if we do a thought experiment, yeah, just think about this logically. Okay, if we ask, like, okay, so do young men or old men get heart attacks predominantly? Old men.
Oh
Yeah.
man, of course.
Yeah. Prostate cancer, is it a young man's disease or an old man's disease?
Unfortunately, another old man's disease.
Yeah. type 2 diabetes. Well, I don't know now, but generally older men. Okay.
Yeah, I mean,
Now,
so yeah, unfortunately, yeah, I'm seeing much more younger people developing type 2 diabetes, but once again, that's a lifestyle, I think,
yeah.
rather than, but yeah, generally
So,
an older person's illness,
yep.
because obviously insulin resistance develops because you've used and abused your body over the last 40 or 50 years, yes?
Yep. So again, the point is then, if testosterone was such a bad thing, but these things are happening, all these negative consequences are happening when a man's testosterone level is low.
Yeah,
Surely, if testosterone was bad, we'd have more young men dying of heart attacks, more
yeah,
young men having prostate cancer. And incidentally, the link between TRT and prostate cancer has been debunked, and more men having type 2 diabetes. But we don't. When men are in their prime, in their 20s and 30s, they're in the peak of their health and they have high testosterone levels. So if
yes,
testosterone was so bad, yeah,
yeah,
then we'd expect to see more heart attacks in 20 to 30-year-olds, more type 2 diabetes, more
yeah,
cancers, but we don't. So
yeah,
it's all about, you mentioned again, super physiological. It's all about staying within the
yeah.
physiological range.
So let's just talk about ranges then for testosterone, because obviously you do a blood test, and say for example, I came to see you and I said, look, Shaz, I'm not feeling very, great. I'd like you to do a blood test and just check my testosterone levels. By you doing a blood test, you have to be below a certain level before we'd consider supplying anybody with anything, just making sure everybody's aware of that. You can't just rock up and say, well, look, take my bloods, or, I feel like I'm not, doing too well, and just give me medication. That's not the
Yep.
way the system. That's not the way it
Yep.
works. So
So yeah, that's right. But there's an issue with this, and there's an issue with the whole of medicine and these figures. So, for example, how did we get these numbers from 8 nanomoles per liter to 30? That's roughly the range. It used to be 12 nanomoles was the cutoff. If you was below 12, then you was classed
yeah,
as, hypogonadic and you need
yes,
TRT. Now it's gone down to 8 nanomoles. But where'd you get this range from? This range is from a cohort of men that includes young, fit, healthy men,
yeah,
70-year-old men, very fit men, very ill men. It's
yeah,
all
brilliant.
lumped together. So to be honest, it's not an accurate range.
Yeah,
Yeah. And what we need to do going forward to develop the field of testosterone is to look at the person. First of all, we treat the person, not the number. And what we want to do with that number is get an age related level. We can do that. The figures are there now. So
yeah,
rather than stick to those numbers, then look at what is happening in a similar cohort, rather than
yeah,
look at this broad range, which includes young men, old men. And this is the model of the one size fits all. Yeah.
yeah,
And this is something where we're into personalized medicine,
yeah,
where we will go to the levels of genes, blood tests, looking at an extensive medical history, and then preparing, compounding something bespoke for you. This is the whole ethos of personal medicine, because
yeah,
personalized medicine, because this huge range is not reflective of where you are in your life's journey.
yeah,
So we want to identify, first of all, an age related number. Yeah.
yeah,
But also, what we want to do is we want to relate it to your thyroid function, because a low thyroid function can also decrease your
yeah,
testosterone. We want to relate it to your adrenal glands. Are
yes,
you or your cortisol levels? We want to relate it to your metabolic profile. All of these things, and also your medical history. Remember what we said about the opioids? So
yeah,
maybe your testosterone levels have been decreased because you're taking
yeah,
opioid drugs. So a simple quick fix would be to wean you off those and maybe start you on something like LDN. So
yeah,
it's not a case that you'll come to us, and say you have low testosterone. We'll look at you holistically.
yeah,
And if we can just nudge you back into a higher range by doing a few simple
please,
tweaks, that's what we'll do. Rather
yeah,
than, again, just take this and
yeah.
go away.
So also, I just wanted to mention on a side note as well, with obviously testosterone and testosterone replacement, I hear lots of horror stories about needles and injections. Yes, that is one mechanism of delivery to a patient, but we also do testosterone films.
Not yet. This is why I had the baseline, because
Okay,
we were experimenting with the film. So I
okay,
had to go to come off my testosterone,
yeah,
and we actually put it in the book of film. I'll show you the film, in fact. So this is, you've mentioned the film, so I'll show everyone. So it's
okay,
this is the CoQ10 film.
Okay, so
So
essentially we are compounding these films to give patients an alternative route of medication delivery into the system, yes?
yeah, so I'm gonna put it in. So it goes on the buccal mucosa. You place it like against the cheek, yeah. So I just want to emphasize this cheek, yeah. Then from here it dissolves and it will go straight into circulation. So it
Okay.
bypasses the stomach. Now
How
we
long will
tried
that
to
take to dissolve in your mouth?
less than a minute. It's nearly gone.
All right, okay.
So it's mucoadhesive rapid dissolve.
Okay.
So we tried to put testosterone in there.
Yeah.
And we did some lab tests and we found that we could get the testosterone into the film and it was coming out into the blood. We tested all of that, but it
Yeah.
wasn't high enough and it would require multiple doses.
All right, okay. Okay.
So we were looking at, but you have cream as well, but cream is good. Cream has its and the gels has its good side and bad side. So the benefit is when you take testosterone, one of the side effects is it increases your production of red blood cells. That's why you feel like loads of energy. But you don't want your blood looking like ragu. So you have to do regular blood tests and donate blood. So you keep your then we measure this by a number called the hematocrit. If it goes over 54%, then you have to stop your testosterone therapy and donate some blood, or just make sure that you're hydrated, because if you have more fluid, then the red blood cells have more area to swim around in and it's concentrated. Now, one of the benefits of the gels that they will increase the testosterone level, but they won't increase the hematocrit so much. That's one option. A downside is that you can get transference losses. So your wife, your other half, can become hench as well. So that's,
I was going to say, you can also get obviously localized reactions with the gels as well, isn't it? So,
yep.
So,
and there was a story, went to this synopsium in Europe it was the European testosterone clinic, a TRT. There was all the doctors came, and there was one story this doctor gave, and he was prescribing this gel for this man, and his levels weren't shifting.
Okay.
And he kept prescribing it, and the guy, he was putting the cream on, but nothing was happening. It was like it was a puzzle.
Okay.
Then the guy took off his shirt. It was just like a rug. So it wasn't. It wasn't getting absorbed. So those are funny things, but they're simple things. So if you're super hairy,
shave the area before you apply. Yes. Makes sense. Yeah. I mean, but unfortunately, like I said, until you explain this, I mean, a lot of people probably wouldn't know. So until you've talked about it and mentioned it and counseled them appropriately, which is, I think, very important as well. As long as you've had that discussion and they know how to use and what to use, then obviously it makes the outcomes of that treatment so much better, doesn't it? So
I mean, you've had like when you've asked someone to, once I was working as a pharmacist and the guy was ordering too many Ventolins. So, okay, show me how you use the inhaler. And he started unbuttoning his shirt. What's he doing? He sprayed it on his chest.
Oh, wow. Okay. Yeah. So, I mean, I had a patient who was using a suppository without removing the plastic. So yeah, it's you hear it all. So, yeah, I mean, you'd think nobody would ever do that, but unfortunately, it does happen.
And so we had a label. So, when you have the creams, apply locally, obviously apply locally to the rash. Sent the prescription away, had a phone call half an hour later. Same lady phone. She goes, it says apply locally. I'm going to Spain next week. Can I apply it there?
Oh, okay. So yeah, something as simple as that, isn't it? So I mean, in terms of summary, then I think this was just two people who are interested in innovative and original ways of managing long-term health conditions that isn't normally covered under the normal scope of the National Health Service and conventional medicine as such, but does provide patients with relief. And I think that's where we need to be. And it is not just in terms of, you have a symptom and we're treating it. We're using a holistic approach to try to not only treat what's going on, but potentially also prevent issues happening in the future.
Yep. I mean, if you like this video, please subscribe and hit that like button, and let us know if you want us to go over anything that is of particular interest to you. If you need help with your symptoms, just pop a comment up, and also if you want us to do live webinars, we'll do that. And if you're in the Derby area every second Sunday, I mean, we were meant to be there today. So 2 Sundays from now, we usually have a workshop in Insomnia, the coffee shop on Burton Road. Feel free to come in and ask us questions. You can meet us in person there.
Perfect.
Okay, cool. So yeah, call it a day then.